I think you can see we've got Jonathan Spergel kindly came out here from Philly, UPenn, told us last night at dinner his favorite cheesesteak restaurant in Philly. I'm always asking people from Philly which to get different answers every time. I guess it means there are a lot of good ones. So he's going to talk today about something food related as well, eosinophilic esophagitis from bench to bedside, translating to clinical outcomes. So, Jonathan, thanks for coming and looking forward to your presentation.
Thank you for inviting me. Philly is known more for than cheesesteaks. It's actually probably one of the better foodie cities these days because it's the rest. A lot of these new chefs open up restaurants in Philly because it's a lot cheaper than New York and Washington and expand. So Philly, the James Beard Awards. So Philly usually wins a lot of the James Beard Awards, which is the award for the best chefs and restaurants in the United States. All right, on to other topics about food. Let's see. All right, my disclosures. You good? Okay. You good? Okay. Um, I get money from various pharma companies to do lots of clinical trials in EOE, and I help design several clinical trials. We're going to talk a little about sort of epidemiology and symptoms, then a little about the pathogenesis, and then how that got to treatment. So just discussing EOE from a standpoint. So eosinophilic esophagitis, um, like many atopic diseases, it's really risen in the last 20 years. It was the same rise we've seen in every other atopic disease. There was debate last night whether atopic disease is the right word, maybe allergic disease. Uh, Depends on how you define things. It's about 1 in 1,000, so it's actually not considered a rare disease anymore. Um, and this was a study that we did almost a decade ago now. And this is one of the lovely things you can do with EMRs. You can sort of use your EMR to create birth cohorts. So this was a birth cohort that we created that looked at what happened when we followed these patients over time. So this was patients who were just in a primary care network. So we had everything from birth to what was going on. And they've now followed them to wherever, almost 18 years of age. But what we found is this atopic march that patients start with atopic dermatitis, and then they are prone to develop other allergic diseases. This is what was found years and years ago. Um, but this concept of what we see in the bedside is like patients with AD are like 2 times more likely to get food allergies, 3 times more likely to get EOE compared to the general population. One of the biggest risk factors for developing eosinophilic esophagitis was having a previous history of IgE-mediated food allergies, so foods that would cause anaphylaxis and hives. So really showed that these things were sort of linked to each other. The other thing is these patients with EOE, whether you look in pediatrics or adults, are very likely to have allergies. So this is just looking again at this same patients with EOE, looking at our EMR, and you can see about 2/3 have seasonal allergies, about about 50% end up having asthma, and just under 20% having atopic dermatitis. And that is anywhere from about 2 to 5 times more likely compared to the general population after controlling for everything else. So they're really a much more likely to get that. The other interesting thing, this is sort of unbiased look at things, is that it's much more common in whites. And African Americans seem to be protected. We'll talk about that a little later on, but that was a real phenomenon. People are like, oh, you're not looking at the other population. But when we've looked and everyone else has looked throughout the world, there is a reason why some diseases are more common than others. It's not just a selection bias. There are real genetic and medical reasons why, and we'll get to that in a minute. This is looking at the adult, and it's the same thing. The things are anywhere from much more likely in the adult population to have asthma, allergic rhinitis, atopic dermatitis. What's also interesting is not only are more likely to get sort of the classic comorbidity diseases that we always think of, but you are also more likely to get autoimmune diseases. So this was sort of when I trained as a fellow, you would either get type 2 diseases or get type 1 diseases. You shouldn't get both. That's probably not true. You probably have a T when you start getting more atopic diseases. You probably is not just skewing to Th2. You're having dysregulation of your T cells, so you're getting more T1 diseases. And that was true in this adult cohort, and this has now been seen in other diseases. So this is looking at an adult cohort of about 1,000 patients in the adults and about 3 million controls. So huge numbers. And it was very clearly that we begin to see all these things. So who do we think about EOE? Who in our atopic population do we think about it? It is the ones I talked about last night. And I apologize if people are hearing this again, but this is sort of a classic sort of patients have that initial inflammation that hurts to eat, so they have food refusal, failure to thrive. As they get older, that esophagus starts not working so well. They get vomiting, dysphagia, belly pain. In adults, the esophagus get hardened and stricture, and then that's where they present with food impactions. When we look at an esophagus, so this sort of normal esophagus is your grade 0, and this is sort of Icaro-Rano's EREFs. And as you get on, if you can think about this like an atopic dermatitis, you get these thickened, you get edema like you would see with allergic rhinitis. You get these rings, you get exudates, which are just micro abscesses of eosinophils. You get these vertical lines called furrows. So these are all the things that you can see when you do an endoscopy. These are similar things that I think we can think about. I like looking at the skin in atopic dermatitis that follows. This is the most recent definition of EOE. It changed just a little. In the initial definition, you had to fail a PPI to qualify. That was taken out. And it was taken out because it was realized about 50% of the patients with esophageal eosinophilia responded to a PPI. Then there were all these reports of people responding to PPI also responded to diet and steroids. And then people went back and looked at mechanisms, and they realized that PPIs have effect on STAT6. So we realized that, hey, maybe the PPI should really be considered a medicine, not just a way to diagnose patients. But it gets complicated because you can put people on diet and steroids and fail, but you put them on a PPI, they get better. It's because those patients have reflux. Eosinophils just go where tissue damages. So sometimes you can just get eosinophils from reflux and not be due to a food allergy. So it's not as straightforward, but I always tell patients, if you get better with a PPI, hey, you got better with a simple medicine, over-the-counter medicine. You're getting better now, so it's much simpler to do. All right. The other thing I like to think about from a mechanistic standpoint is this overlap with atopic dermatitis. When I think about atopic dermatitis, you get really is that uncontrollable itch and this neuronal mast cell activation role. There's probably the equivalent would be barrier disruption. You get eosinophilic, esophageal dysfunction. Then you get this barrier dysfunction, right? So in skin, you get the dryness, you get transepidermal water loss. In EOE, my mind, that's like the reflux and the losing the barrier. And then you get that inflammation, the redness on the skin. You can see the same redness in EOE. The lichenification, that thickened skin is like the food. It's like the strictures we get in EOE. So there seems to be a big overlap with AD, but just in a different tissue. So when we think about that, like what does that come back to for pathogenesis? And this sort of goes back. So first, let's take a step back and let's go into genetics. So the people probably know these are Manhattan plots. Manhattan plots are looking for these skyscrapers, and these are various genetic plots. These are some of the original ones from about 10 years ago. And there is some important genes that show up. So TSLP, which is an important alarmin, work done by colleagues here in Seattle, really you can see it's an important gene for lots of atopic diseases, and it's a major risk factor for an EOE. Caprin 14 is a protease, and that's more esophageal specific. Why TSLP? And when we did these controls, we use matched Caucasian population. Interestingly, the African American population does not carry this TSLP risk allele. And that's probably one of the reasons why they do not get EOE as commonly as everyone else. The Asians, Hispanics, all carry this TSLP risk allele at the same frequency as Caucasians do. So that's why EOE is really sort of distributed pretty equally in those populations. But the African American population does not. People are keeping doing it more. This is one of the more recent ones from about 3 years ago. And now you get 11 new loci, 5 common allergic loci. These are just some of them. Like most atopic diseases, it is not a single gene. It is a multifactorial gene. There's things that play a role in fibrosis, like SMAD, which is work really looked at by Seema Aceves, the JAK2 inhibitors. Polymorphisms are there, and they play a role in eosinophilia and IBD. Obviously, there's ones that affect T cell stability, the ones that are in the cytokine locis, the 5q31. So a lot of things that we look at before are in that pathway that play an important role in ATP. So this is looked at, this is work done by the Cincinnati group, said, let's just look at the African American population and totally different risk alleles. The TSLP doesn't show up, suggesting that there's differences in each population. There's a real differences in the groups, and you can really see that genetics and ethnicity does play a role in some of disease progression, right? But it's not simply genetics, right? So if it was simply genetics, then every monozygotic twin should get it. But it's about 40%. And if it's strictly environment, then basically you would expect siblings, basically you expect dizygotic twins and monozygotic twins to be the same, right? But since there is a clear increase in genetics and in the environment, and the environmental factor probably plays a key role in utero, and that's why siblings are so much less than dizygotic twin. So there's some risk factor during pregnancy or early birth that has an effect. What that risk factor is completely unknown. It's probably the same combination we see in everything else, whether C-sections, early antibiotics, feeding preferences, cleaning preferences, all those sort of things. But there's clearly a genetic role as compared siblings to general population is thousands of fold higher, but there's also an environmental role. So you'd really need to look at both. So now let's take one step back and say, hey, we know genetics. What about can we learn from our bench and from the animal studies? So I always like to go back to my work when I did as a fellow. So this was what I did as a fellow. I made mice itch and wheeze. And this is sort of the sometimes you do things, you don't know why you do things. But when we did these mice, we were trying to sensitize mice, and we were trying to sensitize it through the skin. And we shaved the mice, and I couldn't get the patch to stick on the skin. So what I would do is I'd take a piece of tape and like get all the little pieces of hair off so the patch would stick better. Worked great. The mice developed atopic dermatitis. We would now give the mice an allergen in the skin. They would develop asthma. It came the model of the atopic march. If you made the mice eat it, they would get EOE. Little did I know that my taking the piece of tape on the skin was tape stripping. Didn't know it. And that was the key to make the model work. So sometimes you just have to be lucky. And this model is still used. People still use it 25 years later. So it's sometimes it's you really just when you get something to work, you have to understand why you're getting things to work. But this really shows that you need a sort of barrier disruption. And when we look at this, this is now they using instead of using tape stripping, this was work done by um we collaboration with David Artis, and I think Steve Ziegel is also on this paper. Looking at the role of TSO, looking at the same model now, using a vitamin D analog. And that really showed this was not IgE dependent, that you can knock out B cells in these mice completely developed EOE. But if you knocked up basophils or TSLP, the mice did not get esophageal eosinophilia. And mice could get food impactions, but you can see a food impaction in a mouse. This is food impaction in a mouse esophagus. If you you give them anti-TSLP or you block the basophils, they do not get it, showing that TSLPs were really critical for the development in a mouse model of EOE. So the other thing that worked that was done, now sort of going back to the clinic, you can show that this was really T cell dependent work done by Mark Rothenberg's group, Len Farou's group, and several others. It's shown that it was T cell dependent and that was Th2 dependent. We began to look at could we find activated T cells in our patients, right? So this is when we took minimally reactive Th2 cells. So we took CD3, CD4, CD445 oral cells. We would take these cells, we would culture them with milk peptides in a control population who just had EOE without, or patients who were milk sensitive. And the patients who had EOE would have the cells would proliferate, while the patients would not. And these were looking at the IL-4 positive cells. And if we looked at them, and you can see that there was some variability in this, right? So control patients and tetanus response were great. So the way that we had to sort of work it out to work was do it as a ratio to milk response of a tetanus response. And by doing that, we actually have a really good way to identify these patients who have these T cells and potentially a lab test now, because we know it wasn't IgE based on the mouse work and work done by giving Zola that didn't work. That these were T cell responsive patients. So this is now trying to become a CLIA certified test, which I've now learned is a really long and slow process because you have to do it randomized prospectively, and we need like hundreds of patients to get this to work. I think we needed 200. We're like 175, so we're almost there. We hope sometime this year this will hit the point, and then we'll make it a CLIA certified lab test. The other work that was done really fascinating, done by Wayne Shuffler's lab out in MGH, they were able to look at single cell expression, looking at cells from the esophagus and looking at biopsying them. And when they did that, they were able to identify these memory T cells that expressed this GPR15, and they were really along those lines. Then they were able to further identify them looking at these cells. They were not only GPR15, but they were really Th2 cells. There were these Th2 per Th2 cells that really expressed, milk-specific antigen. In collaboration with them now, we've been able to identify a specific T cell receptor in a lot of these patients, so suggesting that a lot of this is a true T cell specific disease that we can identify in a lot of these patients. But it's not just a T cell disease. And I think when we think about EOE, and we'll talk about it later, that I want to change the name because it's eosinophils are not so important, and I'll show you in a few minutes. But epithelium also plays a really key role in this bet, and this is
Focusing that on T cells that are
sensitive.
what about patients who are a different food?
So The challenge is, so we're trying to do the assay for soy, wheat, and egg, right? So the other major EOE triggers. It is it has been really tricky. It looks like we can get it to sort of work for soy and wheat. Egg, we haven't. You have to get the right peptides and you have to get the right patients, right? A lot of these peptides are have endotoxins. We have to clean up the peptides, right? The standard peptides had endotoxin. We have to clean it out. So we need to. So we're working on it. Milk is the most common one, so it's worked well. But we're working on the other foods as well. So it's
You would presume that
you could find. We should be able to find all of that. Yeah,
if the presumption is different patients,
have different
they have T cells,
to the other.
wheat peptides specific.
Correct.
So,
Yeah, that would be the assumption. Have we been able to prove it yet? No, but that is the assumption. I would agree with you completely. Um, so we think about a barrier dysfunction. So this is work from Mark Rothenberg's group that's really and Sphinx 5 is important that you see like a lot in the AD and some other deficiencies. So this is in Sphinx 7. So in Sphinx 7, when you patients with EOE have a decreased expression of Sphinx 7, and it's due to IL-13 expression. When you knock out Sphinx 7 or Sphinx 5, you get this reduction, you make the esophagus leakier. So TER is looking at resistance. When you knock it down, your esophagus is leakier. And not only you get reduction in Sphinx 7, you also get reduction in desmoglein as well as filaggrin. So you basically get a leakier barrier, just like you do in atopic dermatitis. We can't measure transepidermal water loss in the esophagus, but it's the same concept. Your esophagus gets leakier and things will come in through more. The other thing that happens in the esophagus is you get you get bad repair. You get this epidermal mesenchymal transition to get leading to fibrosis. And it's probably due to the fact that you get this reduction in these repair cells, the CD73, that are in the basal level of the esophagus. And that's probably due to downregulation from IL-4 and IL-13 that sort of play a role in that. It causes that downregulation. What happens then when you knock those out, you can see that in a normal esophagus, sort of IL-4 and IL-13 here, those upper panels, you see this thickened esophagus. But when you knock out CD73 here, you don't get that reduction. So these leads to abnormal repair in these cells. It's the stem cell, the stem cell like, it's a mark of a stem cell like cell. It's part of in the basophil. It's a basal cell that is a marker for a type of basophil that has stem cell like properties. I don't know what the exact name of that cell is besides the basophil, but stem like cell properties. It probably everyone else. Someone probably has a name for it, but I don't know what it is. The other thing is you get loss of barrier function. You get reduction in tight junctions, right? We talked about that. You get also the reduction of Occludin and Caldin-1. You get upregulation of TLRs in these esophagus as well. So you get a lot of barrier dysfunction. The other thing is it's not straight work of the esophagus. This is work that we've done with the group here at Den Royer. You can also see an upregulation of interferon gamma. So, and interestingly, don't forget in atopic dermatitis, you get also upregulation of interferon gamma. So you can really see both in pediatrics and in adults, you get this shared expression of interferon gamma genes in both alpha and gamma, but a lot of interferon gamma just in EOE. And it's probably, I think, due to the repair process. As the esophagus begins to repair, you get this upregulation of these genes along the lines. And the other thing is people have now begun to look at that and said, hey, let me identify these patients. So this is work done by the EOE consortium, which is called SEGER, we're a member of many other institutions. And so work done by led out of the Cincinnati group, really sort of done single cell analysis and tried to do some EOE phenotypes, and they came up with three phenotypes. This sort of normal early on, this inflammatory one, and then the fibrostenotic one. My thought, I would have drawn, honestly, the circles a little bit differently. I would have called all those the same, and then you would have two phenotypes, and I would have called the adult two, the stricture, the adult onset, a different phenotype. But I also think people in the steroid group may be a completely different group at all, but I think patients can move from one to the other. So I think there is some differences there, but I think we're beginning to understand EOE is not just one disease, but it's probably like many things, different phenotypes as we can think about it. The other thing is when we think about EOE is what happens when things are normal. So we took that same cohort and looked at what happens when histology is completely normal, when eosinophil counts are down to like 0, right? So they looked at patients in pediatrics and adults, looked at patients with less than 15 or truly 0, right? Less than 15 was that artificial number we took. But when you looked at that, you can see when patients are less than 15, there was a fair amount of some gene activation, but even down to 0, there was some 6 genes, including this cadherin, that was there highly expressed, suggesting that there's some transcriptional alteration that we need to think about long term. And you can see these are the genes that using a 15, I just want to note two things, right? One is that when even down to 0, there was still some upregulation of things from not normal, including MUC4 and cadherin that play a role there, that things still along those lines. And these probably may play a role in some of the fibrosis. So maybe going down, and I want to go back and do this analysis, looking at difference in therapies, right? Because we know, taking what we know, things like asthma, right? And like, I don't know how many people remember the CAMP study. Some of the old folks know the CAMP study. So the CAMP study was this big asthma consortium study that they gave people asthma meds really early on. And then there was one called PEAK, where they try to give asthma meds really early. Can we prevent long-term fibrosis? No effect on long-term disease. Patients did better. Asthma inhaled steroids worked great, but really had no change in lung function. And I don't know in this cohort, are these patients treating with inhaled steroids or they're being treated with diet? But my guess, I have no data to support this, that there's a difference. I mean, there have been studies looking at inhaled swallowed steroids for EOE, and long-term use of swallowed steroids did not change fibrosis very much because there was they still had the same underlying disease position. And I wonder that's what's going on here. The other thing I want you to know, there's some
long-term damage.
correct.
So do we have any therapies like you think biologics might change that?
We don't know. That's a good. I think either biologic might do better or diet may do better. I don't know which one better. But the other thing I want to point out is there's a real difference between 15 and 0. 15 is a lot more gene activation, and it's probably important to get closer to 0 as possible. But I think that's going to have better long-term disease. So when we think about treatment, right? So this comes up with the question, what's the right treatment? Right? We have to make sure we have the right therapy. And we think about treatment in two basic ways: diet, so nutritional therapy, and then pharmacologists, so medicines. Dilatation is a short-term fix, but patients and adults with strictures, nothing works great on strictures right now. Maybe the new biologics might, but nothing has worked well. So we use dilatation as sort of as a temporary fix, and then we go to maintenance therapy of either nutritional therapy or with pharmacological therapy. The other thing to think about, and this was work done by Alex Struss over at Penn, that she just presented at the recent GI meetings, that they followed 100 of our patients who moved over to the adult side and looked at what happens when you keep things well controlled. So they define well controlled as having 2 biopsies in the less than 15 in the normal range. What they were able to show pretty quickly that the better you keep them under control, the less likely that you're going to get strictures. So 77% reduction in strictures and 90% reduction in food impactions. So very highly significant, that makes a difference for these patients, that you really can see these patients get significantly better over time. So it really shows that, hey, the better control, the better you are, which not be surprising. Anything in medicine, hey, you control inflammation, it's a better thing to do, right? So what about how to control inflammation? This diet, there's 3 basic ways that we do diet. Elemental diet works great. No one does it. It works. It's your highest response rate. It's in the mid-90s in peds and adults, but no one really does it. Elimination diets, we'll go over those. They work about 2/3 of the time, and allergy testing diets work on at best at 50%. And that's when doing skin and tests. Based on all these meta-analysis, no one does allergy testing anymore. It didn't work as well. It was a lot more work. It was easier to guess. The question is what to guess with. So there's 2 ways to guess. There's a so-called 6 food elimination diet, and I love to ask gastroenterologists, okay, what are the 6 foods? And they go milk, egg, wheat, soy, nuts, fish. Okay, so you realize that peanut's not a nut, so they counted peanuts in it, and they said fish, so they counted all seafood. So if you really want to count this, there's probably like 30 foods, right? And then if you go to Europe, when they said wheat, that was wheat and oat, because they just did all gluten, and they said oat sometimes is contaminated with gluten, so they just added gluten and barley, and it got really big. But it worked in about, as you can see in that initial study done by Amir Kalawaga, that it worked in about 75% of the patients. But when they started adding foods back, it was primarily milk, wheat, and egg. Really very little fish, shellfish, and tree nuts. So they did a sort of a prospective study where they did 4 food elimination and added foods back. They had a little lesser response rate. Now we're in the 60%, but it's the same foods. It was milk, egg, and wheat. Most patients were just sensitive to 1 food. So that led to these 2. So 64% were 1 food, 20% were 2 foods, 8% were 3 foods, and 8% were 4 foods. No, percent of the people that responded. So of the 63% that responded, what group were they? So there was 63% of their 78 children responded. In those children, it comes out to be only 25 children. Of those 25 children, how many of them were allergic to 1 food? How many of them were allergic to 2 foods? How many were allergic to 3 foods? And how many were allergic to 4 foods? Of that 25, 16, so 64% of those 25 children who did all the food introductions end up being allergic to just 1 food. No, EOE. So I'm not talking about IgE sensitization at all. IgE has not played a role at all. This is, when I call things being allergic, I do not, my mind, you can be allergic. Being allergic is not just IgE, it's non-IgE as well. So, right, food sensitivity to me is more like lactose intolerance or drinking too much coffee and getting jittery. That's food insensitivity. Allergy means you have a true immunological response to a food. So there were 2 prospective trials in comparing 1 versus 6. This was the adult trial, called SOFID, and you really saw, interestingly, no difference at 15 eosinophils or 10 eosinophils between the 2. If you go down to a deeper response at 6 or 1, they begin to show a difference, but there really was not much difference between the 2 groups. Patients got randomized, no real difference. This was sort of an adult. When there was a Um, there was a pediatric trial that showed the exact same thing, not much different. So based on this, that milk was the main trigger. So many of our patients start with a simple milk elimination diet. That's going to work for about 30 to 40% of the children. So people often ask, what about baked milk? So about half the people who respond to a milk diet can tolerate baked milk. So if you want to start with the baked milk, your number's now going to be in the 20% range. But that's a really easy diet to do. You just have to avoid cheese, ice cream, and milk. But but that's often people want to do that, like want to go slowly. We typically will start with milk and go from there. So what about medicine? This is the oral budesonide trial that was approved in Europe. There's a slightly different one in the United States, which is the Eohilia. In this one, you see about response rate just under 60%. The dose that they used in this tablet was 1 milligram BID. In the United States, the Eohilia dose is 2 milligrams BID. They saw about a 20% rate of localized fungal infections in thrush. Most patients are relatively asymptomatic, and we can treat them pretty easily with that. Our dose that we typically use is about 1 milligram once a day. We do not use those high doses. We we will use Eohilia if people want to, but we often still concoct it ourselves by taking the budesonide tablets off label, obviously, and mixing them. You can mix them with anything. Patients don't like to do Splenda. They want to do something more natural, so we do maple syrup or honey or applesauce. You just can or eat or drink for 30 minutes afterwards. Um,
Is this commercial product any better than off-label?
No.
Budesonide?
No.
It's more expensive.
it's more expensive. And the companies don't like me to say that, but yes. What about all the biologics? What are the biologics taught us, right? So this was one of the first two biologics that were treated since we thought this was an eosinophilic disease. What about anti-IL-5? So one was mepolizumab. As you can see, they got treated for 12 weeks. Very few patients got down to zero. In that population, once you stopped, everyone got back. But about just over half got down to less than 5 when they did that original trial. But symptoms didn't improve. So people said, hey, let's try to do a slightly better one. So this was one that I was the PI on. It was this large study on resolizumab, and we got 3 different doses. And what was interesting, again, we had a few people got better. The higher dose, you had more patients respond. Numbers were lower, but symptoms was the same throughout the populations. Everyone's symptoms were the same. No big improvement in symptoms in any of the patients. So people said, hey, we didn't get enough people down to zero. We need to use a better eosinophilic agent. So people tried 2 other eosinophilic agents. One was this anti-cyclic 8, and they basically got everyone's eosinophil counts down to 0. And when they did the large phase 3 trial, you can see basically 90% of the patient had eosinophil counts less than 6. But symptoms didn't change one bit. Symptoms were identical. When you look down at the esophagus, looking at the EREFs, looking at how much the esophagus looks normal, looked the same. Had no improvement whatsoever. So this drug got pulled from the market. Then people benralizumab. What happens with benralizumab? Let's see if we can get patients better, right? Eosinophil counts, you can see over 87% got less than 6. Really got everyone better. Symptoms, really no difference. So this really proved to the point that eosinophils are not important for the disease, because if you knock them down to 0, patients don't get better. Eosinophils are a marker of inflammation. They're the easiest thing to count. They're not there normally in the esophagus. I, I wish we could change the name of the disease to call it a T cells epithelial esophagitis, so the TEE, right? Because I think that would be a more accurate name, but that's never going to happen. People like the name of EOE. But EO's probably there, not having a really critical role. So now, what about other drugs looking along the pathway? So there've been a couple ones looked at. There's been IL-13 analogs, and obviously dupilumab. So the IL-13, this was one of the first IL-13 drugs. And what you saw, we got counts beginning to get better, not so much in the placebo group. This is looking at peak eosinophil counts. You saw patients got better. And symptoms in general, 8 out of 10 patients had improvement in symptoms. So it looked a little bit more promising. Secukinumab, which is now finishing up the phase 3 trial, which the results should be announced shortly. Again, counts went down. Looking at the response, it was about looking at the number of patients. You can see there's a significant improvement from 116 down to 25. And the other interesting, a lot of patients didn't respond initially, responded later on, but there was improvement in symptoms. So this is the main side effects of this one. Seems to be relatively safe. In the study, no major risk factors. So what about what's been approved? So this is what's been approved. This is the EOE Liberty study, which patients got randomized to 2 different dosing regimens, dupilumab weekly or dupilumab every 2 weeks. And if you look at eosinophil counts, which are in the panel Part A and Part B, Part A was just weekly versus placebo. Part B was the 2 different dosing regimens. You can see the response rates in the 60s to 70s in that study. So eosinophil counts definitely dropped down to less than 6. But what was interesting was 2 things. When you look at symptoms only approved in the weekly study, not in the biweekly study. So you really needed and we looked at 24 weeks in that study, so it was a really long response. You begin to see separation as soon as looking at this at 12 weeks, you begin to see stuff. But to get a really big response, you seem to get better over time, right? Looking at the panel here, you can, I have to go back. You see that separation at weekly, beginning at sort of 10 weeks, but it continues to improve over time. And we've definitely seen that patients at 6 months are good, but even better if you go to 52 weeks. There's a continual improvement over time. That this is a slow-acting drug for EOE.
There's no other indication where you use dupilumab weekly.
Correct.
So they must have had a suspicion.
When they did the initial phase 1 trial, open label study, they did weekly. So that's why they stayed with. Yes, but they did it weekly because said, hey, this is what worked in the past. So but they expected the 2-week to work. They were surprised that it didn't. Many of our patients now who are on dupilumab responding at every week can now wean to every 2 weeks and do fine. So in these studies, these tend to be very severe patients who are failing everything. So I think like we think about in asthma or in atopic dermatitis, you have some moderate to severe patients, they may need the weekly, and your more mild to moderate may get by with every 2 weeks. If you look at endoscopy appearance, both they look the same, which was either the weekly or every 2 weeks. So they both work looking at that way, which was different. The anti-IL-5 drugs didn't show an improvement in the esophagus. Safety profile, the big thing is injection site reactions. Patients complain on the injection. This is true with dupilumab in general. We always tell our patients to take the drug out 24 hours in advance, if not longer. But that is the big problem that we have. This is the pediatric study. It was a high dose and a low dose. Low dose is sort of the normal dose. The high dose is basically twice that. In this study just got published a few months ago in the New England Journal. Same sort of thing, 60 to 70% got counts less than 70, but only the high dose had an improvement in a symptom score. And the pediatric symptom score was really complicated to do because pediatrics, you had to do a different symptom score by age. So we had this various symptom changes in symptom scores, but you were able to see it there. So it seems that in pediatrics, in EOE in general, you may need a much higher dose. So looking at what we know about the pathway, so what this has told us that you really need to inhibit sort of the cytokine role, the IL-4 and IL-13, which causes sort of induction of intercellular spaces and causes more eotaxin, but just blocking the eosinophil probably doesn't play much of a role, or even leterlimab, which blocks IL-5 and the eosinophil, probably not a big role. It's much more blocking the cytokines and induction of potentially the basophils and along those. We're going back to what we know. The anti-TSLP drug is in its phase 3 trial now. I do not know what the results are. We did our interim data lock a couple weeks ago, so we'll know that soon, but I have no idea what the results are. But they're looking at that drug as well. So the other thing people always ask that, hey, in these clinical trials, we told people you can't add the foods back. Right? You have to do that. So we did a trial looking at patients we know who had a food-induced EOE. Could we add the foods back into the diet? So these foods that basically led to biopsies being positive or basically eliminating the foods, and we did the most common foods, milk, eggs, soy, and wheat. And they had various biopsies. We looked at everything we can think of, various symptoms, something called FLIP, which is looking at esophageal compliance. And we also looked at some T cell function. So basically, we gave them dupilumab. We got biopsies at 3 months. If the biopsies weren't normal, they were out. If the biopsies were sort of better, but not completely normal, you got 3 more months on to go back to true drug indication. And if things were normal, we added a food back in, right? So we had 1 serving size, see if foods got better. And then we did a biopsy 3 months later. And if the biopsies were normal, you got up to 2 serving size. And at month 3, you got up to 3 serving sizes. If the biopsies weren't normal, you just stayed where they are. If they were worse, you had to reduce the food in half, right? So what did we see in general? You were able to add the foods in. You can see there's a few points higher in eosinophil counts. Looking at symptoms, patients generally did better, a little bit worse when we added foods in. And when we looked at whether patient reported or caregiver along those lines, but in general, people did fine. What you looked at here, so this is looking at individual patients. You can see most patients did fine, but it's a few patients, when they add the foods back in, got worse. We reduced the food in half, so it'd be month 3. And then you go back, like, great, now you're doing fine. Now they begin to tolerate the food. So it takes some patients longer. You need to be on the drug not only 6 months, maybe 9 months to a year to add that food back in. And these few patients that got worse are the ones that caused this, those few patients that have more symptoms. So in general, you can add it back in, but it's probably better to go slowly. If you went fast, I think we would have a lot more failure. So when we add foods back in now for patients with EOE, we tell them to slowly add the foods back in. The other thing we looked at, we used our same T cell assay. Could we see differences there? So we took our PBMCs, looked at patients before they went to dupilumab and after the dupilumab. We looked at our ratios, looking at responses. If patients didn't respond to tetanus, or they got dropped because we couldn't do this comparison. So we looked at our cells stimulated with tetanus or milk antigens, did flow. And what you found in general is that if you look over time, there was this general slow decline in a milk proliferation. And if you sort of looked at beginning, before no food, then foods plus Dupi at the endpoints were not statistically significant yet. Their ends are a little small. We hope to have, as we finish our last 2 or 3 patients in the study, that will get that significance. So I think we're beginning to induce tolerance. That's my hope. I don't know if that's actually true, but that's what I'm really hoping to see with these patients. So just to think about this, EOE is a common atopic disease. We all see it. It overlaps with lots of our other atopic or allergic diseases. It's not IgE mediated, but it's a T2 disease with barrier disruption. When we think of treatment, we can remove the trigger. Sort of milk is the most common one. You could think about other foods. Treatment, we sort of start with simple things like a PPI, which I think to me is like a moisturizer in atopic dermatitis. Then you can think of swallow steroids like ACSs in asthma. And then for people who fail those things, or you can jump right to a biologic. There's debate whether you go PPI right to a biologic or you use swallow steroids. And I think that's really like we say nowadays, that shared decision making. If someone has lots of atopic diseases, hey, I'm gonna give one drug for everything. Good thing. Some people don't like to take medications. We want to do an injection up to the patient. So I will stop there and happy to take questions. So thank you everyone for coming and your attention.
Thank you very much for the excellent presentation. I remember when the molecule for Spergel was very encouraging. I think they dropped from all.
Yeah.
It has no.
They completely dropped it. They have a cyclic 6 molecule, which is looking, I think, being used for chronic urticaria. But I have not had much contact with the company, but I know the cyclic 8 has been dropped.
Other questions? Questions from our outside audience?
Yes.
Question about maybe just a little bit the past and reports themselves for them how you and you should have more. And what was its measure and you see there is there an for using it for diagnosing patients and looking for not one IgE
Right. What we do, so it's a flow-based assay. So we take the flow, we isolate CD4, CD5, CD45 RO memory T cells. We add new peptides, you let them proliferate and you measure this proliferation. So the starting ways we do a proliferation assay. As we mentioned before, we've done milk, we're trying to do other foods. We're also trying to we're trying to also look in food protein juice enterocolitis, which is also another non-IgE native food allergy. I don't think I even have enough preliminary data to say whether it's working or not, but I know the three people who are working on it are looking at it. So we're trying to identify that as well. Those are the two diseases that we're looking at now. We're not looking at other food allergies. When we look at patients who have IgE-mediated food allergy, it gets a little confusing. We've ruled them out as a control because I think the T cells do respond, and that makes it a little bit tricky. We've talked about whether or not, hey, would this be a good assay to screen patients who want to do oral immunotherapy, and if they have high proliferation, maybe they would be a bad candidate because then they would get EOE. We've discussed that. I have no idea if that's true or not, but we're thinking along those lines. I don't know, what other food allergies are you thinking of? Anything else?
I was thinking in terms of
Yeah, so once we get this done, we will do a prospective study using this as a clinical trial as a way to treat. To give people to do the test. They don't know we have to. Our being is to get this do the clear certification first. Yeah, it's been a really slow process because we get blood from lots of patients, and then you have to find patients who started then that yes, they did make elimination, and then they know that it works. And then we have to go sort of, okay, we've got the blood, here's the assay. Ooh, did they respond? And then we go back and like, oh, you did respond. So therefore you count as a positive patient. Well, you didn't respond. Now you count as a negative patient. So it's been a tricky process. Yeah.
We're going to figure that you go with following children and that control based on the whole quality less.
Yeah.
You think it's true for adults, given what you mentioned earlier, that even if you remove the pills, there's still this whole
So so this was just peds going through to adults. So there's adult data from Alex Shrumman and Evan Dallin that's looked at delay in diagnosis, right? So not looking at eosinophil counts, but looking at when symptoms started to when they were diagnosed. And that seemed to show the same thing. The later you're diagnosed, the longer you have symptoms, you're more likely to have strictures. They didn't look at biopsy simply because it's hard to really not treat people. Like, hey, we're just gonna watch you. We're not gonna treat you and see what happens. Maybe you could in adults. But there's hints that's the same thing true. The better you diagnose them, you're less likely to get strictures later on. So yes, yes and no. So yeah, there was another question.
Yeah, regarding the ASLP risk allele, I guess I find it interesting. Do we know another allergic diseases, black patients can have more higher coverage?
Right, like an atopic derm.
Right, and also,
So this,
so why do you pick specific areas that?
I mean, it's multifactorial. So I mean, I think I don't know. I mean, I don't know if so like an atopic derm, which is or asthma, right, which is often higher in African American population. That they should be the same TSLP risk allele, but if there's other risk alleles, like I don't know if like the filaggrin risk allele for atopic derm was identified, that was originally identified like in Ireland and the UK, which was all Caucasian. But there's a different similar epidermal risk allele in Japan. There's one in I think you need multi things. You need you need it's multifactorial. So I my guess is having that TSL that TS having the protective TSLP risk allele in African Americans is protecting them for EOE, because maybe you need that one of those risk factors for starting that pathway. But it doesn't protect them for AD or asthma. Why? It's a great question.
One thought I always thought maybe the reduced access to endoscopies could be, we know that, generally patients with lower social concepts like less access to.
Yeah, so people have looked. So, so that was everyone's assumption, right? That's the case. It was all because we don't. But there's been several groups now that really have looked at that and looked at, especially like in sort of the South, right? Said, hey, we have a more diverse population. We'll see it more. And they see the same thing. And then when we looked at our population years and years ago, one of the original studies by one of the GI fellows, probably 15 years ago, and we said, because I always felt like, hey, it's just a disease of rich white boys, because I was also rich white boys from the suburbs were getting it. So you can do these pretty interesting. It's sort of fascinating how you can get people from addresses from geomapping. You can get income levels of people without asking their income. So you can link that, hey, you live in this block, your income average of the 50 houses in this block is so and so. And when you sort of control for that, so you control for income. The only thing that showed up was ethnicity, was being white was a risk factor. So being black was not. So the income was not that was like, oh, that it's not a thing. They present what's interesting, the patients who are Afro-American who have disease tend to be some of our harder to treat patients. They seem to be much more resistant disease. And looking at the genetics, they were very different. The genetics of that population is very, very different than the Asian, Caucasian, and Hispanics. Hispanics is sort of a broad term, so it depends on what you think about Hispanics. But Asians and Caucasians share genetics. They back migration across Asia into Europe was the same, right? that population has the same genetic pool. Africa is a very separate genetic pool, and in Africa, there's 3 separate genetic pools I've learned. I'm not a geneticist, but they've told me there's 3 separate genetic pools in Africa. The group at the NIH is now going down to Africa and trying to answer that question by just randomly biopsying people in sort of different populations to see what goes on. But like in South Africa, right, where there's a large African American population, they only see EOE in Caucasians. They almost have no African American population. So would really suggest that there has to be a protective allele, and why for EOE only and it's not for atopic derm, I can't tell you. So it's this idea that it's more than just access to care. I know that's the hot topic these days, but I mean, look at so many other diseases we think about, right? So if you have certain diseases, I mean, Tay-Sachs is only in Ashkenazi, most commonly in Ashkenazic Jews. Celiac disease is much more common in certain ethnicities than others. Same thing with IBD, right? Asthma is more common. It's pretty broad, but there's definitely increased risk in African American populations. There was these large studies done by, I forget what, Hershey from Cincinnati, looking at birth cohorts, right? And certain birth cohorts, African Americans had more asthma. The Caucasian patients had more food allergy, even when they both started with atopic dermatitis. That the African patients were much more likely to get asthma, while the Caucasian patients were more likely to get food allergy, right? So there's differences there. Why that is, whether it's genetics, environmental exposures, don't know. Well, great things for people to work on and figure out. A lot of projects.
Questions from outside?
Yes, my question was outside, says the bill,
Perelman.
feeling the surgery did an IL-13 for diagnosis.
Has not been
Repeat the question.
so does dupilumab, due to its effect on IL-13, affect wound healing? There is no data looking at that, and nothing that I've heard. And I don't think our ENT colleagues who do all the sinus surgeries have said anything. So not that I know of, but I don't think anyone's really looked.
This is, can you hear me? This is Vinod here,
Oh,
one of the
thank you.
community.
I try to make things more interesting.
This is Vinod here, Dr. Spergel. Can you hear me?